Yeah, thank you. Welcome, everybody. Thanks for coming today. Thanks to Danielle and Kobe and Tom for having me today. I'm really excited to be here and share with you a little bit about what we're seeing here at VCU in terms of mental health trends. But I'm also going to talk a little bit about national mental health trends, and that's pretty well mirrored in what we're seeing here at VCU. The presentation itself is probably about 30 minutes. I wanted to leave lots of time for questions and collaboration or feedback that you might have. And there's been a pretty big overhaul at our center in terms of our clinical model change, and so I want to make sure to highlight some of that because that's different than maybe information that you've had prior to this academic year. So talking about mental health trends is not necessarily something that is new to you because this has gotten a lot of national press over the past 5 years in particular, and really began during the Virginia Tech tragedy in 2008. We really started to see more national media attention on what was happening on college campuses around students who had mental health needs, how college campuses were responding to those. The threat assessment teams that are newer to college campuses was a direct result of what happened in the Virginia Tech tragedy. And so this is something that you've likely been exposed to, but as anything, it's sort of, pop culture or media has one perspective about what's happening, and then those of us who are working with students have sometimes a slightly different perspective. So I did want to share, though, that I think that the media attention really is bringing to light the fact that a lot of students are coming to college and either developing or having their first experience with mental health concerns, or are coming to college who have pre-morbid mental health concerns. And one of the things that has been a big push from that is this attempt to reduce the stigma associated with mental health, and I think that's awesome because there have been a lot of people in previous generations that have not sought mental health services because they didn't feel like they could. There have been cultural taboos specifically for men and people of color, and so I think we're doing a much better job of reducing the stigma associated with seeking mental health services. But then what happens is that we end up with this influx of students, and then we have to be creative about how we meet their needs. So I'm going to talk about sort of what's happening nationally, and then again what's happening here at VCU. Just wanted to just share this one video because I think that this is a good example of some of the student-driven initiatives that have helped to reduce stigma and increase access to mental health services. This is at University of Toronto, but I think that if you looked on YouTube, you would find these kinds of videos and these kinds of initiatives happening everywhere. Here we have a really active Minds chapter, and so I know that there's a lot of student involvement around reducing barriers for students seeking mental health services, and just wanted to show this short clip about some of the creative ways that students have helped us do that.
Conversation going about our mental health. They agree. As far as I go, as far as I know, I've always got a place called home. Across all the seas, it's fine by me. It's I'll never be far from home.
write the hashtag Let's Talk on your hand and make it your profile picture.
So one of the things that that you saw there is this real drive to reduce stigma and reduce taboo around seeking mental health services, and how students really are trying to get the word out there. And I think the other thing that has become a changing face of just our society in general and has impacted the way that we deliver and get access to folks with struggles with mental health is social media. And so I'll talk a little bit about some of the things that we've done and that other universities have done utilizing online platforms and social media to try to increase awareness and deliver interventions. But I do think that that's something that has also impacted the way that our young people are interacting with each other and with society, which may be contributing to some of the mental health concerns. And so we'll talk about that a little bit more. So just some national trends that we're seeing. A note that a lot of this data in my presentation is taken from the Center for Collegiate Mental Health, which is at Penn State. And the CCMH data is pulling together data from 139 colleges and universities nationwide who are all using an electronic medical record called Titanium. And then we upload our data, VCU participates in that. We upload our data to the CCMH study, and they're able to then look at all that data from across the country and see what the trends are around national mental health for college students. So it represents about 110,000 college students who are in mental health treatment. So it's a pretty rich data set. So some of the things that we've seen that may be changing this is institutional enrollment. And institutional enrollment is up just in the past 5 years, 5.6%. There's a lot of people who have hypothesized that that's a direct result of the crash in 2008 around economics and people just not being able to find jobs, deciding to go back to school to re-specialize, or because they decided this was a great opportunity to do that. But even before that, there's been a pretty significant increase. If you look from 2001 to 2011, that's 32% more people enrolled in colleges than there used to be. I think that one of the things that we've done nationally is really talk about how students should have greater access to higher ed, and that there are often more job opportunities if you have at least a bachelor's degree than if you have a high school education. And so I think for those who are able financially and sociologically to attend college, there's more of a push to do that than maybe there was 40 or 50 years ago. So along with that, you would expect that there would be increased utilization in counseling centers. So the increased utilization is up almost 30%, and the number of attended appointments is up about 39%. But what I found really interesting was that the institutional enrollment does not really account for the increase in number of students that we're seeing, because the number of students that we're seeing is actually 5 times more than the institutional enrollment. It's grown that much faster. And I'll show you some of our data, which certainly reflects that and is representative of that. And so then that changes how we deliver our services. One of the other things that's happening, I think, for people overall is that there's either a greater reporting of mental health concerns, maybe because of this reduced stigma, or there's a greater experience of mental health concerns. And some of this is from data for people who are not just part of a clinical sample, but are from the larger sample of the population at wide. And so a lot of people ages 18 to 24 are saying that they're experiencing primarily depression or anxiety. If you had asked me 10 years ago what the primary presenting concern was, I would have told you it's depression. More people were struggling with mood symptoms than with any other thing, and now it's anxiety. And so we'll talk a little bit about what that might be about. Of particular concern, though, is the increased number of people who are experiencing suicidal ideation or who have made suicide attempts. And there's some data from the American College Health Association that reports that since the 50s, the suicide rate for young adults has tripled. And suicide is the second leading cause of death for people who are age 18 to 24. The first is accidents. And so that's really devastating and such a preventable way for us to get involved around saving young people's lives. certainly from my experience as a clinical psychologist and from overseeing a lot of people who work at the center, a lot of students are coming into the center experiencing what is either their first emotional crisis, or they're experiencing a number of sort of smaller micro crises, and then suicide feels like their only option. And so there's been a lot around why that might be the case, and some discussion around that will follow. But I do find it concerning that a lot of our young people, when they start to struggle, think that suicide is sort of a next best step. It really is a permanent solution to a temporary problem, and it's really sad. So we've done a lot on campus to try to increase our efforts around suicide prevention, and I'll talk about that too. So again, why is this happening? Why are there more people seeking mental health services? Why does it appear as if mental health utilization rates have gone up at a greater rate than we would expect the actual concerns or mental health experiences to have gone up? There's a lot of hypotheses, and it's really hard to say which is the one or which is a cluster of things that are contributing to this. And some of them are conflicting. And so some of the things on the slide are even conflicting, because the truth is that we don't really know why, but some of the hypotheses are that we're making headway in reducing stigma. And so those efforts that you saw in that video, or that students are doing, and that mental health practitioners and that universities as a whole are doing to try to reduce barriers to services are likely having some effect. And those messages are getting out there such that people are more likely to come through the door and more likely to seek services. They're not really seeing any evidence that people coming to college have any higher pre-morbid or pre-college mental health concerns than was the case 10 years ago. And so while there are others who say that this increase in resources on campus has allowed people with mental health concerns to come to college when they wouldn't have done so before, some of the data doesn't really back that up. I do think that there is less stigma and more opportunity for people who have pretty significant mental health concerns to be successful in college, and that certainly wasn't the case 20 or 30 years ago. 30 years ago, we really started to move away from institutionalization of people with significant or serious mental health issues, and began to really work in communities to try to make sure that folks with diagnoses of bipolar or with schizophrenia or with really chronic major depressive disorder had access to services and could be functional people in society. And we've done such a great job of that nationally, and such a poor job in some other ways, because there aren't enough wraparound services for people who really have serious mental health issues. But because of the advances in psychopharmacology and the advances in mental health treatment, people who were once not able to come to college are likely showing up at our doorsteps. And so we see a lot of students who come to school who have a bipolar diagnosis, or who have had a major depressive episode with psychosis, and are able to manage that and come to school still. And I think that's wonderful. It's amazing. And we're doing a better job, I think, as universities around supporting those folks, in part because of this shift, I think, just socioculturally around parents and society expecting that colleges and universities really do function as in loco parentis. And so in the absence of parents, I think universities really expect that if I send my kid to your school, you're going to take good care of them, and they're going to have their needs met there. And it's not just academic needs that are important, but it's the holistic approach to providing care for students. And so the colleges have really responded in increasing their efforts around things like student affairs and student health and student counseling services and wraparound services that promote social, emotional, and academic growth for students, especially those who are living on campus. One thing I also wanted to mention too is that I think there's been a lot, especially in the media, around like what's happening with our younger generations. These, folks who are 13 to 24 and who are on the phones all the time and aren't connecting face to face and maybe are less resilient. There's not really a lot of data that I could find that backs that up in terms of a correlation between that and mental health concerns. But there is something interesting, I think, happening around immediacy expectations and the expectations for which people's difficulties are going to get solved, or which people are going to feel better, because everything that we have is so quick and instant access. I think there's difficulty in tolerating distress. There's difficulty in being patient. There's difficulty in kind of sitting in yourself, because rarely do you have to do that. It used to be, you'd go and you'd wait for a bus and there was nothing to do except read a book or talk to somebody or look around. And that's not happening anymore. And so there is, I think, a cultural shift around how that might be impacting both interpersonal connections with one another, expectations for not having to wait for things, and then also sort of this instant access to things that are going to fix it. And so there is some hypotheses that that's contributing to people's anxiety in particular, and there might be something to that. And then, of course, this whole concept of helicopter parents. And so parents for the generation that we're seeing in colleges currently, having had this reputation of rescuing their kids from any failure, never letting them experience a failure, intervening academically with sports, everybody gets a trophy kind of thing. So I think one of the things that people are wondering about is if then people don't have the opportunity to have micro hardships as they're growing up, little setbacks that they just have to learn how to cope with and talk about and be resilient around, that's having an impact when they get to school and then something happens and they just don't have any experience to fall back on. I mean, if you think about one of the first times that you had a setback, whether it was you didn't get accepted into a social group, you didn't get accepted into a major that you wanted, you had a relationship end, you had a loss of somebody that you cared about. Think about just for a second how you coped with that, and the pieces of that felt like they were really hard at the time, and the pieces of that felt like they were doable. And then if you reflect now about kind of where you are, and all of those things that have happened to you and all of those pieces of information that you draw from around knowing that you are a resilient human being. A lot of what we're seeing, I think, especially with the 18-year-old, 19-year-old, 20-year-olds, is that they just don't have the same depth of experience, range of experience, or opportunities for experiencing those kinds of things. And then when something happens, they just don't know what to do. So part of what we're seeing, I think, is that, although it's a lot of things. So talking specifically about university counseling, I'm going to share with you some data about our last year in particular around utilization, but wanted to give you kind of the broad strokes about who we are and what we do, and said I would talk about our new clinical model. So consistent with other university counseling services across the country, our utilization has increased dramatically over the past 5 years, and I'll show you some data about that in just a few minutes. But it has been really overwhelming. And actually, just hot off the presses, we had, in September of 2015, we had 271 unique clients come into the center, so 271 students presented for services who hadn't been there before. And this year we had 424 in September of 2016. So that's an increase of 56.46% of students in just that 1 month coming into the center for seeking services. And those are the kind of numbers that we've been seeing for years in terms of comparing data from this year to last year, or last year to the year before that. And so one of the things that we've done is we've shifted our clinical model, because we really kind of ran into, in the past several years, this bottleneck where we are the primary mental health provider for students on campus. Our services are free. And we've done a good job up until the past 5 years of being able to meet the students' needs who come in for services. It's usually around 8% of VCU students utilize our services. And so what began to happen, though, is that we just didn't have the ability to meet all of the students' needs who were coming in. And so we ended up, I think, with a wait list at its peak last year around 200 students. And what that meant is that we were doing a really good job of seeing students who were in crisis, students who needed immediate intervention, students who were really struggling, and we were not doing a good job of meeting students who were moderately distressed, who were having some milder symptoms. And that was really frustrating, because we know that if we can intervene with the students who were moderately distressed or mildly distressed, that they're going to actually be much more likely to stay in school, they're going to be happier, they're going to contribute more to this community, and yet we felt really stuck because we just couldn't get them in, and the people who who were feeling suicidal, who had just been sexually assaulted, et cetera, needed our priority. And so we've completely changed the clinical model. And what that looks like now is that when students come into the center and say that they would like to be seen for therapy, that they're interested in receiving services there, they're going to be seen that same day. And so they are seen for what we call a referral and assessment meeting, or a RAM meeting. Isn't that clever? Everything here is a RAM. But, and we had 351 students just in that month between August 24th and September 29th who came in for RAM meetings. And they're 15 to 20 minutes long, and in those meetings we're talking to students about why they're there, what they're needing, some of their symptoms, some of their history, and then we're making some recommendations for next steps. And those recommendations are sort of a decision tree based on a lot of variables, and we have some options in-house, but we also have some options out-of-house. And so one of the things that we've really tried to be clear about for ourselves internally is what is our scope of services? What is really doable? What can we do well? Because that was a piece that we really didn't want to lose. We did not want to lose doing good quality clinical care. And so we're having to make some determinations about what that's going to look like, because really what we do is we offer brief individual therapy. And I will show you some data around numbers around what that looks like. But most students are seen between 3 and 5 times at university counseling services, and that's really appropriate for a lot of students. That's really what they need. They've had a recent breakup, they have had some moderate depressive symptoms, they're feeling kind of anxious, and so they don't need a longer course of treatment. But then we do see students who need a longer course of treatment, and so we've tried to get creative about what we can do around providing those kinds of services, and I'll talk about that in the moment. But the students who are seen longer term are students who really meet clinical criteria for needing longer term services, people who have had trauma histories or who have characterological disorders, who have really chronic major depressive disorder or significant debilitating anxiety, people who have clusters of symptoms, people who have maladaptive coping strategies, who are using substances or food or sex in ways that are not. So students can come into the center and say that they need to speak with a counselor right away. Faculty and staff can walk students over, and a student can be seen right away that same day. And then we also offer after-hours crisis services. So one of us is on call 24/7, 365, and I think that's a really helpful resource for both students and for faculty and staff. We've had faculty and staff call because they've gotten a concerning email, or they're reading a paper and they feel worried about somebody, and they're able to consult with the counselor on call about best next steps. We do provide couples therapy, and we define couple however the couple defines it, and we also only require that one person be a student, and so that's really helpful for a lot of people who are not both in school. And then we have a pretty vibrant group program. So we have interpersonal process groups, and actually our group, I'm really proud of our group program. It's nationally renowned. It's one of the most thriving group programs in college counseling all over the country. So we serve about 12% of our clientele through our group program, and right now we have 13 active full interpersonal process groups. And then we also have some theme-specific groups, and some of these are in direct response to what we're seeing in terms of what's walking through the door. So our recharge group is a brief 5-session intervention for people who have anxiety, and we have multiple groups running at any given time, and so there's enough time to do 6 groups over the course of the semester. And since anxiety is a presenting concern that we see most frequently, this is specifically around skills for managing anxiety, having some experiential components around practicing those skills, and then if somebody needs something else after that, then we can get them referred to where they need to go. DBT is dialectical behavior therapy, and DBT Group is really great for those students who need more intensive care, who have higher acuity, who are really struggling, and who also need individual therapy. And so this is a small subset of our population that doesn't have the resources to sort of get this more intensive outpatient experience in our community, and so we wanted to be able to provide it to students here for those who really need it. And so students who are in DBT 2 hours a week, and then they also receive individual therapy for 1 hour a week. And so if there's something going on for the student and they really need that for a semester or for more than a semester, we're going to try to accommodate those needs. And then we have some support groups, and so these are not exactly therapy groups, but there's at least one member of the co-facilitation team who's a staff member at University Counseling, because sometimes stuff will come up in these groups, and it's good to have a counselor present. And so the Rainbow Group is specifically for LGBTQIA identified students, and it's a support group for them. And then the Recharge Group is pretty new, so Tom and then Annie from the Counseling Center co-facilitate that group for students who are in recovery from substance abuse. We also do a ton of case management, and this is helpful for both referring students to the community here in Richmond, but also if a student is graduating or is going home for a winter break or is withdrawing from school, we can help them get connected to mental health services wherever they're going. And then outreach and consultation, so I'll talk about that in a second. So who are our staff, who are our students seeing? Really exciting is that we filled 5 staff positions this year. Some of those were vacant from last year, and so last year was particularly challenging for us around meeting students' needs, but we also got 2 new positions, and so we're excited about that. So we now have 18 senior staff, so full-time, year-round senior staff who are mostly licensed psychologists or social workers. Some of those are still working on licensure, but they're close. And then we have 15 trainees. So the trainees range from second-year doctoral students here in the counseling psych program to what we call advanced mental health residents, which are either postdoc or post-MSW. And so our training program is pretty vibrant. It makes up about half of our staff, and those folks are in supervision for learning how to be clinicians and for providing services to VCU students. And then we have 4 part-time clinicians, so folks who are just here working with us part-time to see clients, and of course our support staff. So they're the face of the agency, the people that you see when you come in the door, and the really cog of the center. We couldn't function without them. Just a little bit about demographics. As you can see, we have way more women than men who are providing services. That's the trend in mental health service delivery right now, is that we have more women who are going into the field than we do men. And that's a shift from the 1960s and 70s, when there were far more men who were psychologists and social workers. And then we have pretty good representation in terms of both ethnic diversity and sexual orientation. I wanted to talk a little bit, I mentioned earlier this change in our culture around how people acquire information and how people get their questions answered. And one of the ways that we've tried to respond to that is by having as many of our self-help resources as we can available in a format online. And so we have a lot around skills, how to cope, how to deal with depression, how to help a friend who's feeling depressed, how to deal with anxiety. And then we have a couple that are more specific to learning skills and are more interactive. So we have some Prezi presentations on here. Coping with overwhelming feelings and managing stress is are the 2 specific ones that are about 20-minute long Prezis that people can sort of self-pace through and learn these skills. And so students can do that in the comfort of their own residence hall or apartment, and we've had tons of hits on that. We had over 1,700 hits on those Prezis last year. So we know that that's reaching some portion of our audience, and that I think it's an effective way for people to get those skills. It also reduces our face-to-face time. Some of you who might be more familiar with us know that we had the Gold programs last year, which were psycho-ed drop-in workshops. And what we were seeing was that people weren't coming to those. So we would have between 6 and 12 students show up anytime for those sessions, and it really wasn't the best way to meet the students' needs, and also looking at sort of demand for resources, it wasn't the best use of staff time, especially when we're finding that the same Gold program that we were delivering in person can be put online, and people are using that at a higher rate. So we'll be putting more of those online, and I think that that does accommodate those requests that students have around having easy access. Just a couple of things I wanted to say about outreach that you might not be aware of that UCS does is that we right now have a contract with Cognito, and Cognito is an online platform. It's a gatekeeper training for both faculty and students around learning how to talk to students who might be in distress or who you might be concerned about. So all VCU faculty, staff, and students have access to that, and you can get to it through our home site. And it's free to faculty and staff. staff, it takes about, and students, it takes about 45 minutes. But the nice thing is that you can kind of go back to it once you're done, and it really does walk you through scenarios around a student comes into your office or a friend comes into your RA office and tells you that this is happening, how do you respond? And I think it's a great tool and something that we're really glad to be able to offer. And then QPR is something that 8 of us are trained in terms of providing gatekeeper training specifically related to suicide prevention. It stands for question, persuade, and refer, and it's for helping people gain comfort in talking to people if they're concerned they might be feeling suicidal, then what to do if it sounds like they are, warning signs to look for, and what to do in terms of referring them to some place where they can get some help. We've trained over 600 faculty and staff in QPR, and it's something that I think has been really helpful around giving students and faculty the tools that they feel that they need to be comfortable having those conversations, because it's a hard conversation to have. It's really hard to ask somebody if they're having suicidal thoughts, and we spend years in training having those conversations, and still it's uncomfortable for some early clinicians to ask that directly. So this is a great training. I've left my cards here, and also other information about UCS, and so feel free to take that on your way out, and if there's a group that's interested in a QPR training, we're happy to put that together for you. So I talked about utilization. These are just our numbers. So last year we had almost 13,000 attended therapy sessions for about 2,400 students, which was a 6.45 increase from the previous year. And since 2013, we've seen a 44% increase. So we've really been drinking from a fire hose, so to speak, and trying to be creative about what to do, but also in a way that's going to maintain the quality of our service delivery, and that's a fine line to walk. Presenting concerns really do mirror presenting concerns nationwide, and so as you'll see, anxiety is number 1, and then it's followed pretty quickly by what I would describe as mood disorder symptoms, so feeling hopeless, having difficulty focusing, feeling moody, and then there's some also interpersonal categories that people are meeting here, so trust, social anxiety, and then certainly the academic piece that we see that's unique to university counseling around career or procrastination or time management. And so those are the sort of clusters in which we see people presenting most often for services at UCS. Demographics, just a note about demographics. We certainly see more women than men, and so we know that I think the rate for VCU is actually like 57% women students and then 43% men. So we're seeing slightly more women at university counseling services, and so what that tells us is that we need to do a better job around reducing barriers for men who need services at UCS. That's a nationwide trend and a VCU specific trend. What we are doing a good job with is really mirroring the representation in terms of race and ethnicity, and so I looked at the data, and this is pretty consistent with the VCU student body makeup, and so we're seeing a pretty good representation of people who are ethnic minorities and who traditionally or historically would be less likely to seek services. And we've done a lot around working with international students, working with African American studies professors around reducing barriers for Black students in particular, and working with Asian student communities to reduce barriers, because those 3 groups of folks were expressing that it was difficult sometimes to come in for services. I think we do probably see slightly more people who identify as LGBTQ, or it's a safer place to say that. There is no VCU data that looks at overall student body in terms of sexual orientation. And then we're seeing more students who are in their 3rd and 4th year than in their 1st and 2nd year. And I'm not sure if that's because students don't really know that we're there their 1st and 2nd year. They don't feel like they need their services as much. But I was really glad to see that this changed this year, because it used to be that our sophomores were coming in less frequently than any other group for services. And sophomore year is a really risky time for students. First year there's all kinds of programming about how to keep people engaged and involved. By your 3rd year, you're involved in your major, you have your social groups, and so most students, or if they're going to drop out, are going to drop out in their sophomore year. And so I was concerned that we weren't seeing students in their sophomore year, but now it's almost equal to 1st year students, so I feel like we're doing a little bit of a better job with that. So areas of risk. So VCU students who come to present for service with us are definitely struggling and have pretty significant risk factors and higher acuity presentations. So over 40% of the students that we saw said that they had considered suicide. And that's disheartening. Over 25% said that they had an unwanted sexual experience. That mirrors national data around sexual assault statistics. And then we're certainly in line with national data around self-injury, attempted suicide, and prior hospitalizations and some stuff around medication. This just shows the change in data around crisis utilization. And so just in the past year, we've seen an increase in over 27% in terms of students who are presenting for crisis services. And this is great. I'm so glad that they're coming in the door when they're in crisis, that they're asking to get some help, that they're really looking for some support and for some services. And we also need to continue to be able to provide the resources to meet those needs. And then you'll see the after hours utilization increased pretty considerably just in the past 2 years. It was 38% and then 24% the last year. So this is the data that I said I would talk about around length of treatment. As you can see, most students are coming in just 1 to 5 times, and I would say that it's probably 2/3 of students whose goals are met at discharge at that time. So a student just really needs 4 or 5 sessions, and then they feel like their goals for therapy are met. We do see students, I think, who within that period we identify that they need more kinds of services, and then we're getting them connected to services either internally or externally for that. But you'll see that the people who are here more than 21 appointments is a very small percentage of students, and those students who are that small subset that I mentioned that need that longer term care, who don't have resources to obtain that outside of VCU, and who sometimes need that sort of patchwork together intensive outpatient program. And then lastly, just wanted to share a little bit about our client satisfaction data. This was from last fall. We do client satisfaction annually. And the things that I wanted to point out in here is not only are students pretty happy with our services once they get in the door, that was some of the feedback last year, which is one of the drives for changing the model, but that it also helped them considerably in terms of staying enrolled in school and feeling like they were able to perform academically. So that really is one of our missions, is to provide those services for students so that they can stay in school, and I feel like we're doing a pretty good job with that. So I just wanted to share that. So that's all I had for you in terms of the formal presentation. Just wanted to open it up for discussion, questions, anything that people want to chat about. I'm open to doing so.
Thank you.